discuss cataracts here. So I briefly want to cover some introductory material, including what cataracts look like, and leukocoria, which is usually the presenting sign of cataracts. We'll talk about the congenital cataract, which presents in children, usually newborns, the senile cataract, which is the most common kind of cataract that you typically see in adults, and then some other causes of cataracts in adults. So a cataract is simply an opacity of the crystalline lens. The lens is the refractory structure that allows for light and the image to project and focus onto the retina. And when people have cataracts, when adults have cataracts, it's not so much a problem that the refractory system is off. It is, but they get this haziness, cloudiness of vision that's directly due to the cataract material inside the lens itself. So you can see cataracts have various presentations. This is sort of your typical stereotypical cataract where you have this opacified material inside the lens, but cataracts can look differently depending on the cause. And I'll show you some different types of cataracts as we go on. That's not so much important to know. It's important though to know generally what a cataract looks like. Leukocoria is a white pupil, and just the designation of leukocoria is important to know because this is often the presenting feature for a patient on physical exam for cataract. Usually we associate leukocoria with children, and that is true. Leukocoria does happen in children, and when it does, it's an emergency. But leukocoria is just any white pupil, and that can be noted by looking through the ophthalmoscope, or it can be noted grossly, or it can be noted even by a parent when a picture is taken. What do we typically get? If we look straight into the flash, we get red eye. But with leukocoria, you would get a white eye or a yellowish colored eye, and that's leukocoria. So in the adult, typically leukocoria means a cataract. But the history and the presence of any other symptoms are going to help you determine what the actual cause is. But typically in an adult, it means cataract. In the child, however, there is a differential diagnosis, and we don't go straight to cataract. We do need to rule some things out because there are some things that can be really alarming and really emergent because some of them can be deadly. Particularly what we're talking about here is the retinoblastoma, which is a tumor, usually in newborns, usually no more than 2 years of age, of the retina. And this is deadly if it's not treated uniformly. Other things that leukocoria can be is a congenital cataract, and that is the #1 cause of leukocoria in children. Retinal malformations, retinopathy of prematurity, which of course you're going to see in premature babies, particularly under 30 weeks of gestation. Retinal detachment, and intraocular infections. And as I've mentioned, leukocoria in a child is always a medical emergency and demands immediate ophthalmology referral. Okay, so the congenital cataract is a major cause of vision loss in children worldwide. It's also a cause of vision loss of children in the United States, but because of superior care here, cataracts tend to be addressed earlier than in the rest of the world. And as I mentioned, congenital cataract is the most common cause of leukocoria in pediatrics. So leukocoria is a sign, it's not a diagnosis. The patient has leukocoria, you need to work up the patient for what exactly is causing this white lens. About 1/3 of congenital cataracts are hereditary, passed on in families. There'll be a family history if you can get it. Another 1/3 are due to an intraocular infection or due to a vertically transmitted infection like toxoplasmosis or syphilis, or it's due to a congenital syndrome such as Down syndrome, Fabry syndrome, and Alport syndrome, etc. And then the remaining 1/3 are idiopathic. And what you're doing in a child who has a congenital cataract, which is any cataract in a child is considered congenital, is you're determining the cause of the cataract, in addition to referring the child to ophthalmology to get the cataract removed. The symptoms include leukochoria or absent red reflex, and this can be unilateral or bilateral. Really, there's not going to be a lot of symptoms though, because this is a baby and they're not really going to be able to tell you a whole lot. You may also note nystagmus. And nystagmus is fast sort of beating abnormal eye movements. And the baby may be unaware of visual surroundings, especially if the cataracts are bilateral, but keep in mind that baby's vision is not very good, especially brand newborn baby, neonate. Take some time for their vision to develop. So you're certainly not going to put a baby up to a Snellen test. But if they're very unaware of their visual surroundings, abnormal compared to other children of their age, then that can be a sign of cataract. For diagnosis, all pediatrics with leukochoria should have a slit lamp or dilated fundoscopic examination, and this needs to be performed by an ophthalmologist to ensure that cataract is the diagnosis. Remember that there are other things that leukochoria can be. So your very first thing after you diagnose or after you note leukochoria is getting the child immediately in to see an ophthalmologist, and the ophthalmologist will make the diagnosis. Generally, you know if it's leukochoria, it's probably congenital cataract, especially if the mother has a history of toxoplasmosis or risk factors for toxoplasmosis or has a history of syphilis. Those are common causes, but we have to ensure that this isn't something else, especially the deadly retinoblastoma. Another thing, and you're not really responsible for knowing this for the USMLE, but the morphology of the cataract can also lend some insight into the possible causes. I'm going to show you some different morphologies of cataracts. You don't need to know what they are for the USMLE, or really even for practice, because it's the ophthalmologist that's going to be doing this examination. What you do need to know, though, is that children with leukochoria, while congenital cataract is the #1 cause, they need to be referred to an ophthalmologist for formal examination to rule out retinoblastoma. So the workup is going to, and this is to determine the cause of congenital cataract, if congenital cataract is the cause for the leukochoria, would be routine labs, torch titers, so that's T stands for toxoplasmosis, O stands for other, which can be various things. R stands for rubella, C stands for cytomegalovirus, and H stands for HIV or herpes simplex virus. The O for other can be parvovirus B19, it can be syphilis, it can be Coxsackie virus, although that can also fall under C as well. So all of those vertically transmitted infections, a lot of those can cause congenital cataracts, but especially toxoplasmosis, rubella, CMV, and herpes simplex virus. So you'll want to get tests for that. Then you also want to get a urine for amino acids, phosphate, and calcium. That's going to help you determine if there's any congenital disorders, genetic disorders. Mostly what we're thinking about here is something called Lowe syndrome. So this is kind of your differential for congenital cataract. If it's infectious, we're really thinking toxoplasmosis, syphilis, rubella, or CMV. I put some other things on here that can be causes, but these ones in boldface here are the ones we're mainly thinking about. Then these genetic and metabolic errors, these tend to be bilateral cataract, but certainly an infectious cataract can be bilateral as well. And this includes Down syndrome, which Down syndrome, a lot of times is diagnosed before birth, but some things that can help you diagnose Down syndrome is just the general appearance of the child. They can have the abnormal stereotypic facies of Down syndrome, and you can get a karyotype if you want to confirm this. Other trisomies like Patau syndrome and Edwards syndrome can also cause congenital cataract. Galactosemia is routinely tested for on the heel prick newborn screening examination, so you really don't need to do anything extra to diagnose galactosemia, as we do this for all babies in the US. Lowe syndrome is what we're looking for when we do that urine calcium, phosphorus, and amino acids. This is rare, but it can be the case. Then these other things, Alport syndrome, remember this is an issue with the connective, I think it's the connective tissue type 4 connective tissue. Don't quote me on that, though. And so this affects the ears and the kidneys as well. So these patients will ultimately have hearing deficits and renal impairment. Usually there will be a family history of this because it's X-linked. It has various penetrants though, so it can be X-linked dominant or X-linked recessive, but it is X-linked. Fabry's disease has skin manifestations as well as renal impairment and some other manifestations. That's also X-linked. Coats disease, this is usually a unilateral cataract. It usually also presents older, not in newborns, and there's a gradual loss of vision. So as far as, Alport syndrome is good to know for nephrologic purposes, for nephrology, but these ones that aren't bold-faced here, Alport's, Fabry's, and Coats disease, I don't think the USMLE is going to throw a congenital cataract at you and put one of these as the cause. But it's just good to know that these can cause congenital cataract. But as far as the USMLE is concerned, what you should be aware of is torch, and then Down syndrome, galactosemia, and Lowe's syndrome. And there's other causes as well. So this isn't even the gist of it. There's a lot more. But I just sort of put your basics here. The treatment for congenital cataract is surgical removal no later than 3 months of age. I've seen some papers that say 5 weeks to 5 months of age, but typically ophthalmologists will treat infants with cataracts pretty quickly. Most infants with congenital cataracts are at risk for subsequent cataracts because they have this disease process that's going on. And of course you should also treat whatever is the surrounding cause, the contributory cause to the congenital cataract, if you can. Regular follow-up with ophthalmology and optometry is going to be important, and genetic counseling is useful as well, especially if it's one of those genetic disorders. Complications include deprivation amblyopia, although the risk for that is less if you treat the cataract quickly. And remember, what amblyopia is it's a disease of the neuroocular system where you don't create a proper connection from the eye to the visual cortex. And so this is exactly what we're trying to prevent when we treat congenital cataracts. The cataract itself is not so much a problem as the complication, which is uniformly going to be deprivation amblyopia if the congenital cataract is not treated. And the neuroocular system really does a lot of growing and developing in that early period, and so that's why we want to get this taken out quickly. Strabismus and blindness are other complications that can develop if you don't treat congenital cataract appropriately. Okay, so the more common senile cataract, this is a very common entity in the U.S. About 15 to 17% of all adults in the U.S. over the age of 40 have a cataract to some degree. There's various degrees of cataract, though. So cataract is just this abnormal material within the lens. It doesn't necessarily mean, though, that you're going to have symptoms. This is the leading cause of blindness worldwide, and certainly you would have to have a significant cataract in order to eventually become blind. Most people over the age of 60 will have some degree of cataract. The question is, however, does it affect the patient in their daily life? Risk factors for senile cataract. So look at the name, senile cataract. Senile just means, we like to say senile means old and crazy, but really senile comes from the same root that we get the word senescent, which just means older. It means something that happens with age. And that's exactly what senile cataracts are. They happen with age. So the number one risk factor is advanced age. That's not really something we can modify, though, because everybody gets older. Cigarette smoking and diabetes mellitus, though, are to a certain degree modifiable risk factors. So cigarette smoking is always a modifiable risk factor. You can always stop smoking. Diabetes mellitus, you can prevent it once it occurs, once you have diabetes mellitus type 2. There is a certain amount of damage that's been done, questionable whether you can totally reverse it. Certainly diabetes type 1 can't be reversed. There is an association with hyperglycemia, so untreated diabetes mellitus, uncontrolled diabetes mellitus is probably more of a risk factor than diabetes mellitus that's controlled. Hyperlipidemia, particularly high triglycerides is a risk factor, and then hypertension is also another risk factor. UV exposure has been listed as a risk factor. I didn't know if I wanted to include it here in senile cataract because technically UV exposure is really trauma to the eye. So that might fall more under the traumatic cataract. So although cataracts are reversible because you can do surgery and you can remove the cataract material, as the mature cataract, the cataract that's fully developed, remains, the lens, the outer portion of the lens, will begin to thicken, and that is not reversible. And so that's why this causes blindness, even though if we get to those patients, some of those patients, after we remove the cataract material, they'll still have visual deficits. So this isn't something to wait around on. Once the patient starts to have a cataract and they're having visual symptoms, you need to remove it. So I just want to introduce you to some definitions here. A mature cataract is when a cataract is present and the patient cannot read better than 2200. So technically the patient is legally blind with the mature cataract. That's a fully developed cataract. An immature cataract is a cataract that's present and the patient can see better than 2200, but they can't see better than 20/20. So this is where most cataracts that present in the US will fall. They've got some cloudy vision. Usually they can see better than 2200, but not quite better than 20/20. And then you can have a cataract that's incipient, and this just means that the patient has cataract material, but it's subclinical. The patient can see 20/20, or whatever their baseline is. So the symptoms of senile cataracts, but really any cataract, really is leukocoria. Visual impairment is the chief complaint, particularly visual impairment that's referred to as blurry, cloudy, foggy. The patient will complain of glare and halos, particularly in the light, when they're looking in the light, because it's the light that's going to cause those halos. Or if they do nighttime driving, they'll see halos as well. There's a myopic shift. So this is interesting. What this myopic shift is it's an increase in the diopteric power of the lens. So the lens becomes to a certain degree thickened, or there's this material inside the lens, and that actually increases the convergence power of the lens. So if you think of what the lens does, it's supposed to appropriately focus the image on the retina. If there's an increase in convergence power, the image is going to be projected before you get to the retina because there's more convergence. And so the patient will actually become myopic. And so the patient may tell you, although usually you need to ask the patient this if you're really stealthy, are you using your reading glasses as much as you normally do? Because with myopia, you will, if there's a myopic shift, a patient who has say they are farsighted, or if they have presbyopia, because they become more myopic, it's going to abate some of their symptoms of farsightedness or presbyopia. So that myopic shift may help their vision as far as focusing on an image. And then monocular diplopia is just simply diplopia, double vision, that doesn't go away when you cover one eye. So they'll have double vision. Usually when you cover one eye, the double vision should go away, but like for instance in strabismus. But with monocular diplopia, that won't go away. You'll continue to have double vision. For physical examination, pretty much you're going to be looking in the eyes, looking to see if there's any kind of cataract. Cataracts are pretty obvious. But you want to examine the patient in a brightly lit room. Make sure you do your full visual examination, have the patient read the Snellen chart, compare it with previous exams if you have them. Then use your ophthalmoscope, look into their eyes. Usually cataracts are pretty conspicuous. I do want to emphasize, though, The examination doesn't end there. You're going to refer the patient to ophthalmology because they're the ones who are going to eventually do the treatment, and they'll be doing this with a slit lamp device. And so just using an ophthalmoscope, that's not enough to formally diagnose cataract. It's enough to tentatively diagnose it, but an ophthalmologist will need to make the formal diagnosis. And like I said before, ophthalmologists can classify cataract into its morphology and how severe it is, and they can also look for any other problems in the eye that can lend itself to decreased visual acuity. And differential diagnosis of decreased visual acuity includes such things as macular degeneration, retinal detachment, vitreous hemorrhage, and these are some things that are a little bit more difficult for the primary physician to see with an ophthalmoscope. So that's why it's important to get these patients over to ophthalmology. So for diagnosis, cataracts, as mentioned, can be apparent with ophthalmoscopic exam, but all patients with cataracts or suspected cataracts should be referred to ophthalmology for slit lamp examination. You should also assess the patient for any possible concurrent illnesses that can contribute to cataract formation. So remember, what are the risk factors? Well, cigarette smoking, you can get that from the history. Hypertension, you can get the patient's blood pressure, look at their charts, do your diagnostic process for hypertension, have them come in again, see if there continues to be hypertension. You can look at their routine labs. You should get definitely a BMP and a CBC at the very least. It would surely, in an overweight patient, be a good idea to get a fasting blood glucose to see if there's any possible diabetes or prediabetes. Also important, and I didn't put this on here, in a patient who's already diabetic, to get a hemoglobin A1C percentage, because that will tell you whether or not they've had hyperglycemia in the recent past, how bad it is. And then a lipid panel is useful as well, again, because hypertriglyceridemia is a risk factor. So those are some things that you can do while you're referring the patient to ophthalmology, and that's useful because if any of these things come back as positive or as significant, then that can be something that the patient can address. They should be addressing it anyway, but something the patient can address to reduce the risk of this happening in the future. So this is just an example of how a patient with cataract may see something. So note that there's this blurriness in the vision. Also is a little bit more cloudy, so it's not quite as darkened, or the contrast is reduced as opposed to normal. And again, you may see this at night. It may not be as bad if you're looking in dimly lit rooms, but when you're driving down the street and you're in traffic and there's street lights and traffic lights and lights from other cars, you'll note these halos. The patient will note the halos. And then there can also, with certain cataracts, there can be a yellowing of the vision. So the patient may not only tell you that their vision is cloudy, but that things appear more yellow. And that's just the color of the cataract refracting back to the retina. That's not all cataracts are like that, though. So this is an example of what I mean by immature and mature cataracts. So they get worse, obviously, with time. And then eventually they can become hypermature, and this is where you get problems with the outside of the lens, and it becomes irreversible. You can remove the cataract material, but the shape of the lens will forever be deformed, and that unfortunately will lead to permanent, irreversible issues. And then here's some cataract. These aren't all of the cataract morphologies, but it's just an example of some cataract morphologies that you can see. This here is an intraocular lens, and with most of the surgical techniques that are done, an intraocular lens is implanted, and that is done after the surgery to allow the patient to see properly. The treatment is simply surgical removal of the cataract material by the ophthalmologist. There are various techniques for cataract removal. and that's going to be determined by the preference of the ophthalmologist, and it's based on the type of cataract, location, other factors. By no means do you need to know anything about determining what kind of surgery to do for a patient with cataract. You just need to know that surgery is the best thing to do for a cataract, and that you need to refer them to the ophthalmologist. Prognosis: 95% of adults will have increased visual acuity following the surgery. So one of the newer techniques that's done is ultrasound fragmentation, otherwise known as phacoemulsification, and this has fewer complications than some of the other the older techniques that are done that are a little bit more elaborate. But that's one way that's done. You can also use lasers and other techniques. So some of the complications include retinal light toxicity, corneal edema, capsular rupture. You can get hemorrhage around the choroid, suprachoroidal hemorrhage, and then vitreous disruption. There's other things that can go wrong too. You would be clued off to whether or not there are complications if the patient doesn't have dramatically increased visual acuity after the surgery. The vast majority of patients will experience a night and day difference, literally, after the surgery has been performed. Some other causes of cataract, just to be aware of that these things can cause cataract, are trauma. I alluded to that earlier. That can be things like UV radiation, heat, physical blunt force trauma, radiation, and then it can be an adverse effect of corticosteroids. Usually these are patients who are on long-term corticosteroids, and it's another one of the reasons why we don't want patients on steroids for long periods of time, among other reasons. And then certain antipsychotics can cause cataracts, particularly quetiapine. This was associated with development of cataracts in beagles. Apparently that's the animal they tested it on. And then there are skin diseases that are associated with cataracts, atopic dermatitis, and eczema. So some other causes of cataracts to be aware of. If you have any questions, feel free to let me know.